All right, it is now 7 o'clock, so we will go ahead and get started. Good evening and welcome to Wednesday Wellness, a free live educational series presented by Trinity Health. Thank you for joining us to discuss aquablation therapy. Before we turn it over to our presenter, we would like to provide a few reminders. Your cameras and sound have been turned off. If you have questions, we encourage you to use the Q&A chat, which is found near the bottom of your screen. Questions will be read aloud and answered by our presenter at the end of the presentation. We are recording tonight's topic, and you will receive an email with the link to the video in the next week. Without further ado, I'd like to introduce urologist Dr. Mander as our expert and presenter on this topic.
Thank you, Megan, for that introduction, and thank you for having me. I'm very excited to be able to talk to you guys about BPH. I want to welcome everybody who was able to join us today. As Megan mentioned, I am Navneet Mander. I'm a urologist here in town. Before we get into the presentation, I wanted to give you a little bit of background about me. I am a Grand Rapids native. I grew up here and went to Forest Hill Central. I went to University of Michigan for undergraduate education. Go Blue. I also had a short stint in Chicago to do research prior to going to Wayne State University in Detroit for medical school and urology residency. Go Lions. So I moved to Grand Rapids with my wife in 2017, and we expanded our family over the years. I am currently a partner at Urology Surgeons here in Grand Rapids. We're currently the largest private practice here in the Grand Rapids area. I believe in all of Western Michigan, actually. I am one of 4 providers in our office that performs aquablation therapy. We are the most experienced in this area in this new technology for treatment of prostate enlargement. I personally do perform most procedures for BPH, and I do believe that aquablation therapy is special. It's really opened up new possibilities for the treatment of enlarged prostate. So we're going to go through some slides, and I will provide an overview of BPH and treatment of BPH. I will then go into more depth through aquablation therapy as a treatment for prostate enlargement. At the end of the talk, I'll be happy to answer any questions that you may have. You may ask questions in the chat. I believe there's a Q&A section at the top that you can kind of type in your answer or your questions, and then at the end, I'll be able to look through those questions. I'll try to answer to the best of my ability. So what are we going to do tonight? Goals of my presentation are to give a general overview of BPH. I will go through some of the more common treatment options for treatment of enlarged prostate. I will conclude with an in-depth explanation about aquablation. I'll talk about why aquablation is different than the other treatments that are out there and what makes it special. So BPH stands for Benign Prostatic Hyperplasia. Prostate is important for sexual function when you're younger. As you get older, it can start to cause problems. It's a normal growth of the prostate over time. It is important to note that enlarged prostate is not synonymous with prostate cancer. Having an enlarged prostate does not increase your risk of prostate cancer. In fact, 90% of men over the age of 80 will have prostate enlargement. If you look at the picture on the right, we can get an idea of the anatomy of the bladder and the prostate. I'm going to see if I can get my pointer to work here. So I hope you can see this, but in the top picture, you can see the bladder here on top. Bladder stores the urine. When it is full, it squeezes to push the urine through the urethra. It's the urethra is kind of that tube that runs down from the bladder. Urethra runs right through the center of the prostate gland. Prostate surrounds it kind of like a donut, and the urethra acts as a donut hole. As the prostate grows, it grows outward, but also grows inward to constrict the urethra. So here you can see urethra is wide open. Here it's constricted. So with increased restriction, the bladder must generate a higher pressure to push the urine through. It just has to work harder to get that urine to kind of go through that urethra. So bladder is a ball of muscle, like any other muscle. If you work the muscle harder, it gets thicker. If I curl weights, my biceps get bigger. It's the same with the bladder. So you can see a nice smooth-walled bladder on top. Bladder on the bottom has more wrinkles. These are basically those muscle fibers that have now grown and hypertrophied. So we call these trabeculations. It's just a fancy word for those wrinkles. These trabeculations, this hyperplasia, this kind of growth of the bladder can progress further and start to cause small outpouchings or diverticulum of bladder. And some of this damage can become irreversible and cause permanent changes to your urinary function. So not everyone with enlarged prostate will have symptoms. Another name for these symptoms are lower urinary tract symptoms, or LUTS for short. Those that do will develop symptoms that fit into two general categories. So the first category on the left is holding of the urine. I like to call these the irritative voiding symptoms. The second category on the right is the emptying of the bladder. I call these the obstructive symptoms. These obstructing symptoms will generally manifest first, and they're caused by the restriction of the urethra, clogging of the pipe, if you will. Some men will have to strain or push to get the stream started. This can cause some pain, we call that dysuria. Some men will take a while to get the stream started, called hesitancy. They may get up to the urinal, have to wait for a while before the stream starts. Once they get it started, it can stop and go. You can have intermittency. You can imagine that having a restricted pipe will weaken the flow. So men will often come into my office and describe their flow as a trickle or a drip. They'll talk about not being able to hit the back of the bowl or the back of the urinal. Eventually, this can cause retention. Your bladder just does not have the ability to push hard enough to get the urine out. So the irritative symptoms on the left tend to manifest a little later in the disease process. This is caused by the thickening of the bladder. Bladder becomes stiffer, cannot hold as much urine, loses the elasticity that is important to storing the urine. Less pliability, more sensitive to the bladder, leads to the bladder wanting to get the urine out sooner. This is frequency and urgency. You're going more often. This can lead to disruption of sleep. If this occurs at night, we call that nocturia. At the most severe end of the spectrum, urgency can lead to leakage. Bladder wants to empty whether you like it or not, and you can't make it to the bathroom in time. This can be quite embarrassing for some men. So the combination of both the obstructive and the irritative symptoms can heavily impact the quality of life. If you have frequency at night, this can cause disruption of sleep. This can affect the patient, but also the partners that are constantly awoken at the frequent bathroom visits. This can limit activities. Patients are afraid to do certain activities because they need a bathroom nearby. You can have sexual dysfunction. This is not necessarily from the BPH itself. Having an enlarged prostate does not necessarily cause erectile dysfunction or ejaculation dysfunction, but it's more from the treatment that of the BPH. The medications that patients are on will often have side effects of erectile or ejaculatory dysfunction. So if we ask men if their symptoms impact life, 99% of them will say yes, their lives are impacted when they have these symptoms. So when patients come into my office, when we're trying to diagnose or kind of work up these patients with enlarged prostate, it's really important to do a lot of different things to fully understand what is going on with that specific patient. Every different patient has a different type of prostate. Every different prostate can cause a different amount of obstruction. So we have to kind of be specific to each patient and tailor our treatments accordingly. Our examinations will usually include a physical examination that does include a prostate exam. We will review symptoms and have you fill out a questionnaire that gives a score of your symptoms. We call this the AUA symptom score. This is a validated scoring system that allows us to assess your response to treatment and to quantify the severity of your symptoms. It's important for us, but also for the patients, as it allows you to see your symptoms on paper and categorize them by severity. Some patients come in and they initially state they don't have any problems. I ask them, all right, how's your urination? Oh, it's fine. When they fill out the questionnaire, scores are high. When we further kind of tease out the different components of the questionnaire, patients will often realize that their urination is not normal and not typical or not the typical normal symptoms of aging. So we will also do some tests to make sure the bladder is emptying well. We'll often perform an ultrasound of the bladder. We call that a bladder scan. We'll also consider performing an ultrasound of the prostate. We will also directly visualize the prostate from the inside with a small camera. We call it a cystoscope. That's to evaluate the degree of obstruction, but more importantly is to rule out other abnormalities that could be causing similar symptoms. These are things such as urethral strictures or scar tissue, tumors, or stones. Treatment for those pathologies or disease processes can be quite different than treatment for an enlarged prostate. This will also allow us to get a sense of the anatomy so that we can find out which surgical treatment option is available or optimal for your prostate. We have about 10 different types of surgery options available for treatment of enlarged prostate, and not everyone's going to fit into the aquablation category. Different treatment options may not be good for some patients, but may be amazing for others. So when we're doing the workup, we're trying to figure out what's going to be optimal for each patient. So which treatment options do we have available to treat your enlarged prostate? If symptoms are not too bad and patients want to avoid medications or surgery, certainly watchful waiting is an option. These patients may eventually progress and require treatment down the line. In the middle, you can see we have medications. Generally, we'll attempt the medications first, and as the prostate continues to grow and cause changes to the bladder, symptoms may worsen. If this occurs, we move on to the right and kind of escalate our treatment to surgery. Surgery ranges from the minimally invasive treatments to the resective treatments, where we actually remove some or all of the prostate tissue. So if patients come in, they report mild symptoms, they have a low AUA symptom score, watchful waiting is definitely a viable option. I do generally run some tests to make sure that we're not causing damage to the bladder or to the other organs. As I mentioned earlier, we'll do a bladder scan just to make sure that you are emptying your bladder. It measures the amount of urine that's in your bladder after you urinate. If your bladder's not emptying, then that can indicate potentially a more severe problem going on. I'll send a urinalysis to make sure you don't have any signs of infection or blood. I will send a PSA, which is a screen for prostate cancer. It's a blood test. I'll also review your general labs to make sure you have adequate kidney function and stable kidney function. Is your kidney function declining, potentially because you have an enlarged prostate and you're not emptying your bladder? So beyond watchful waiting, you start to have more severe symptoms. We have medications for treatment. We've had medications for many, many years, even decades, for treatment of enlarged prostate. We have general categories that I'm going to kind of discuss here. The first category of treatment is the alpha blockers. These are your typical Flomax, Uroxetrol, Rapaflow. These act to relax the smooth muscle of the prostate and bladder neck. So smooth muscle, like that of your colon or heart, contracts and relaxes without your control. Relaxation leads to opening of the channel and less restricted flow. It does not affect the overall size of the prostate gland. Another medication class is the 5-ARI or 5-alpha reductase inhibitors. These are your Proscar or Avodart. So these act more on a hormonal level. They actually do shrink the volume of the prostate down. They generally take a little longer to take full effect. It can take up to 3 months to really have maximal effects. We'll often have patients who are actually on both alpha blockers and the 5-ARIs. We can also treat with low-dose daily tadalafil or Cialis. Obviously, you may have heard of Cialis for erectile dysfunction, but these medications are FDA approved and in the guidelines for treatment of BPH. They work similar to alpha blockers to relax the prostate, but do not affect the overall size. Another group of medications that we may use are anticholinergics or beta-adrenergic agonists. These are your Ditropan, Vesicare, Sanctura, Myrbetriq, amongst others. These can be used in some men to help with irritative symptoms. Those irritative symptoms, again, are the frequency, the urgency, kind of the overactive bladder symptoms. So it's important to note that these are not treating the underlying problem, but they're acting almost like a Band-Aid to improve the side effects caused by that damage or changes that have occurred to the bladder. These types of medications can worsen your ability to empty the bladder and can cause retention. All of these medications can have side effects, some sexual. Over time, these medications can also become less effective. When this happens, we sometimes switch or add medications to the regimen in attempts to improve symptoms. Many of our patients are elderly, and in this population of men, we start to run into polypharmacy. It's a fancy word for basically taking a lot of medications. Unfortunately, when we start to mix medications or add medications, we start to see more side effects and untoward effects. As our research into these medications progresses, we also start to see some long-term effects down the line. As an example, recently came to light that some of the medications that we have been prescribing for years may actually have links to dementia, depression, and in some cases, irreversible sexual side effects. So if medications are no longer effective, or if patients cannot tolerate medications, we generally progress to surgery. Surgery can be broken down into two general categories. We have the non-resective and the resective. So non-resective surgeries, such as the prostatic urethral lift, also called the Urolift, or the water vapor treatment, also called Resume, or the iTind, act to widen the channel without cutting any of the tissue out. We're not actually removing any tissue. These are also known as the minimally invasive surgeries, or MISTs. They are often done with minimal sedation and can be done in the office or small surgical center setting. Patients usually go home after the procedure, sometimes with a catheter, sometimes without. There tend to be low risk of irreversible side effects or complications. So the side effects that we usually talk about are the sexual side effects, erectile dysfunction, ejaculatory dysfunction, and the other side effect that we often will talk about is a risk of incontinence or leakage of urine after the procedure. And the problem with these procedures is that they may not last as long as the more invasive resective surgeries. They are better for smaller prostates, but in my experience, do not improve symptoms much more than medications in those larger prostates that we see. I tend to use these in smaller prostates if sexual function remains a high priority and in patients wishing to get off medications. These are also good treatments for men who may have a lot of medical comorbidities, a lot of other medical conditions that may not be able to tolerate a bigger surgery. So these are the guys who have multiple heart attacks, multiple strokes in the past. They're on aspirin, blood thinners, and they may not be able to tolerate that general anesthetic or more robust surgery. So the next category of surgeries is called the resective surgeries. So these actually remove tissue from the prostate gland to create a wider channel. These are your typical TURPs, or transurethral resection of prostate. That's the old Roto-Rooter. We have the laser vaporization of the prostate, where we remove tissue with a laser that vaporizes the tissue away, and the simple prostatectomy, where we actually surgically remove the tissue through incisions, usually done through small incisions with the robot. This is the most invasive procedure, but it is good for those very large prostates. After these resective types of procedures, patients will sometimes have an overnight stay in the hospital. Pretty much all the patients will have a catheter after the procedure, and they tend to have a more robust outcome in larger prostates or those with different anatomy. So different anatomy, big median lobe, some anterior tissue coming down. Again, most, with the resective procedures, you do have an increased risk of side effects, especially sexual side effects. Most common are the ejaculatory dysfunction and varying risk of erectile dysfunction. In the most invasive surgeries, we're talking about more along the lines of the simple prostatectomy, we also run the risk of leakage. So in a nutshell, the non-resective have a better side effect profile, but less improvement in your symptoms. The resective tend to improve urination symptoms to a greater degree, but at the expense of side effects. So with development of Aquablation, we can offer the best of both worlds and allow us to maximize our symptom improvement while minimizing side effects. It is a resective procedure, so we are removing tissue to create that wider channel, but we're removing it in a safer way. It can also be done in prostates pretty much of almost any size. So Aquablation therapy, long-lasting relief with low rates of irreversible complications. When we perform the procedure, when we perform the Aquablation, we use a camera and an ultrasound to visualize the prostate. This is done under general anesthetic, so you are asleep for the procedure. It's performed in an operating room setting. Because we use the camera and ultrasound, it's unlike any of the other procedures that use only a camera and cannot visualize the entire prostate. We're really only looking at the inner channel for the other types of procedures. Using the ultrasound, we create a map of the prostate, including the borders, kind of the outline of the prostate. We then create a unique patient-specific plan of resection. The Aquablation robot then uses a high-pressure cold water jet to remove the tissue. It essentially acts like a pressure washer to sweep away the prostate tissues. There's a video on the next slide that can kind of illustrate that very well. It is the only resective procedure that does not use heat to treat the tissue. It is very precise. We draw exactly where we want the robot to treat the tissue. It is consistent because it is a robot that performs the treatment based on my prostate map. So it's very calculated. As a result, we have less collateral damage to the tissues that can cause the side effects that we're really trying to avoid. This, again, leads to very low rates of irreversible side effects or complications. The aquablation therapy can be performed on prostates of almost any size. There are very few, usually either the kind of the smallest or the very largest along the spectrum of prostate size that cannot be treated, but we do have other treatment options available for those types of prostates. So if you turn your attention to the right, you can see that we really don't get side effects of erectile dysfunction or orgasmic dysfunction. If ejaculation remains priority, we can be less aggressive during the resection to minimize risk of ejaculatory dysfunction. Approximately 9 out of 10 men will maintain ejaculation after the procedure. Incontinence or leakage rates are very low, 1% or less. So another point, important point that is kind of small at the bottom of the slide, you can read it, is the time required to perform the surgery. So historically, for large or very large prostates, some of the other treatment options, such as the TURP or the laser vaporization, can take 2 to 3 hours of surgery and may not completely resect all of the tissue. This can often require a second procedure to further improve symptoms if they persist after initial treatment, or if there's some tissue that is left behind. The aquablation is reliably under 1 hour, sometimes down to about 30 minutes. Procedure itself, where the robot's actually performing the resection of the tissue, takes anywhere from 5 to 15 minutes. And then the mapping of the prostate and the manual cleanup after the procedure, which I'll explain in the next slide, actually make up the rest of the time required for treatment. So this slide has a nice video that shows how the treatment works. It is important to note that every patient has a unique prostate. Every case that we do is real-time planning and mapping that is unique to the patient. We kind of set things up and press go. Now in the video, it's just going to show kind of a cartoon of the water vapor jet going through the prostate, but it doesn't show the mapping before. In the bottom right, you may see that ultrasound that can show kind of an image of the prostate cross-sectional. That is a real image of the ultrasound that we create. So you can see here on the bottom right is the ultrasound. That's an actual picture of an ultrasound. On the top is the cartoon of the water jet going through the prostate tissue as it does performs the treatment. On the top is the camera, and on the bottom, that black device is the transrectal ultrasound. So we're kind of visualizing with an actual video inside the prostate, and then we have an ultrasound image of the prostate as we perform the treatment. So the video on the bottom right is an actual real video of the water jet treating the prostate tissue. So after the robot is done with the treatment, we go in by hand. We actually put in a camera, we call it a resectoscope, into the bladder. We then use a little bit of electrocautery with a metal loop to control or spot weld the bleeding that occurs around the bladder neck, which is the junction of the bladder to the prostate. This is where the majority of bleeding will occur after the case. And by doing this manual cleanup, we minimize the risk of serious bleeding requiring a return to the operating room and blood transfusions. When we're in there, we also remove the majority of the tissue that was destroyed by that water jet. Some tissue which has been treated will remain behind, but usually that'll drain out in your urine over the course of a few weeks after the procedure. It can often appear like scabs or a little bit of tissue that comes out. So why would someone choose Aquablation? As I kind of mentioned earlier, we will have low risk of irreversible side effects as these are at the similar levels to those seen in minimally invasive non-resective procedures. Minimal rates of erectile dysfunction or incontinence or leakage. We generally see about 10 to 15% of patients with less semen or no semen coming out when they have an orgasm. It is very important to note that this does not mean that you will not have an orgasm or will not have the sensation of an orgasm. It just means that when you have that orgasm, you'll have less semen that's actually expelled out from the urethra. Now, if you were to do a TURP, the transurethral resection of the prostate or the roto-rooter, or a laser procedure, these rates are closer to about 70 to 80% or higher. If you do a simple prostatectomy, it's essentially 100% guaranteed that you're going to have retrograde ejaculation or really no ejaculate coming out. Since it is robotically controlled, we utilize both camera and the ultrasound to create a unique map. We yield a more predictable and consistent response. Aquablation does provide long-term relief. We have robust data up to 10 years that shows durable response. We do have some longer-term data that's trending toward longer-term relief that just hasn't been published yet. In general, we see about 1% of patients per year requiring another procedure to treat residual or regrowth of the prostate. So to compare that to the other types of procedures, laser prostate, transurethral resection, the TURP, and the non-resective procedures can require a redo procedure at rates of up to 13% within 10 years. So 1% per year versus 13%. So in general, it's safe to say that, for all the treatments, you can get at least about 15 to 20 years out of the procedure. So now you've had your aquablation therapy. What can we expect in the recovery? So as with most BPH procedures, we will leave a catheter in place after the procedure. This is usually placed while you're asleep under general anesthetic, so you won't feel the catheter actually going in. This allows the urethra to heal and to hold pressure on the prostate to stop the bleeding. So if you think about a cut on the skin, you get a little cut on the skin, you hold some pressure, and eventually that bleeding stops. This acts much the same. It kind of holds pressure on those small veins that are bleeding, and eventually that prevents the veins from kind of extravasating and allows them to clot. It also prevents the blood from the prostate leaking back into the bladder to minimize clot formation that can cause obstruction. The catheter is usually placed on traction during the hospitalization, so that means that it's placed on a little bit of pressure, so the balloon of the catheter puts pressure on the prostate. Prior to discharge, we do take the catheter off and put it in a more relaxed position. It's a little more comfortable when it's in that relaxed position, and we want to make sure you are as comfortable as possible when you go home. At this time, it is an overnight stay in the hospital, but we are likely moving toward this being more of an outpatient procedure. The catheter will usually stay in anywhere from 1 to 7 days from discharge. Patients will experience some burning with urination for a couple of weeks after procedure. They will have some blood in the urine for a few days, up to a few weeks out. But they can have intermittent blood in the urine for up to a few months out with strenuous activity or heavy lifting. Generally, patients can resume normal activities within a couple of weeks, but I usually do instruct patients to avoid that heavy lifting or strenuous activity for about 4 weeks after the procedure. So I wanted to play this patient story for you, mostly to give you a break from my voice, but also, it helps to hear the story from another patient like most of you. This is a real patient.
When you first start having the problem and you got to go, the worst part is you stand there and you can't go. I'm 62, really active. I take really good care of myself. There was really no easy solutions, but it happens to be a urinary tract problem that could ultimately lead to an erection problem or a sexual dysfunction problem. Everybody says, welcome to the club. I don't want to be part of that club.
Ed's always been full of energy and larger than life. When I noticed that he was not the same, I knew that the BPH was causing him a big problem. He just wasn't as engaged.
BPH, benign prostatic hyperplasia, essentially is an enlargement of the prostate. And in simple terms, when it starts to get enlarged like that, you can't go pee. When I laid down, it seemed to put more pressure on my bladder. Hence, I would get up almost every hour on the hour that you can imagine what it does to your sleep. I mean, literally towards the end, it became just like having a bad nightmare. And I find myself getting severe lack of sleep. Well, that affected my mood, my stress levels. It seemed to cause me constant worry because it was always on my mind.
When the person you love starts to change, it's an unsettling feeling. It started to affect things that we were doing. I mean, intimacy has been a really big part of our relationship, and that was definitely affected.
But ultimately, you kind of mask over what's going on. And I think we try to kid ourselves that I could deal with this. But once you get into a medium to severe BPH problem, you really don't have much choice. You're going to have some type of surgery. The meds don't work at that point. I did all the research possible. I mean, I went on every website quizzing the doctors, and I found out that there's probably 3 or 4 different procedures. They all have potential side effects. And at Men's Health, I don't think this is something anybody should fool around with. I really didn't want to compromise. When I came across the Aquablation, I realized that I didn't have to make those compromises. All I had to do was make the choice. For me, it was a no-brainer to go forward with the Aquablation.
The procedure overall was quick. He didn't have any complications.
I could not believe the result that I had. It was immediate. I forgot what my real freedom was like. I had no problems, no side effects from a sexual standpoint. And it's just amazing that I don't think about going to the bathroom anymore. It was like not only just treating me, but treating my life, my lifestyle. It gave it all back to me again.
Now he's back to his old self. It's actually changed our relationship for the better. It's just completely different. And we've completely reconnected. I'm really grateful for that. I have my best friend back. You don't have to grow distance in your relationship because of something like BPH. For anybody out there who's going through similar things, I would not hesitate to look into this procedure.
It's so different now. I mean, to say it's a 180 is an understatement because once you've been on both sides of it, it's life-changing and life-altering. It's freedom. Boy, let me tell you, I made the right decision.
So although, that video was created by the company itself, probably potentially a little scripted, I do see these patients coming in with the exact same scenario all the time into the office. There's a stigma behind BPH. Men are hesitant to come in and get evaluated. They've heard the stories of the roto-rooter from their fathers and grandfathers. They're afraid of sexual dysfunction. They're afraid of leakage. They may brush off their symptoms as something that's normal aging. With the advances in technology that we have, we can now treat your enlarged prostate in a safe, predictable way without the side effects that we used to see. I have way too many patients that tell me they waited too long to get the surgery done. I have guys who come in that have, this has completely changed their lives for the good. They can go on long trips, they can fly, they can go watch a movie or a concert without having to miss half the show because they were in the restroom. They no longer leak in public. My favorite's the guy who comes in and they're so happy they can get in a full round of golf and not have to stop every 2 holes. But we can't treat these men unless they come in for evaluation. So for the patients, it is important to be your own self-advocate. If you're bothered by your symptoms, ask your primary care provider about your options. Get that referral to see a urologist. For the primary care providers, we're more than happy to evaluate and discuss options beyond medications if men are bothered by their symptoms. So come and see us. As I mentioned in the beginning of the presentation, I'm a partner at Urology Surgeons. These are my partners that also perform Aquablation. We have Dr. Bazink, Dr. McElroy, and Dr. Iwasko. We also have Dr. Lobo and Dr. Kunzman, not pictured here, who do also perform most of the other types of surgical procedures for treatment of BPH. I am proud of our team and what we have created here at Trinity Health Grand Rapids. We were the first and remain the most experienced and robust Aquablation program in Western Michigan. Aquablation has changed the way we manage BPH treatment. I'm very excited to be part of the progress. So if you'd like to be evaluated, please feel free to contact the office to arrange follow-up. Your primary care provider does need to put a referral order in for that to occur. For the primary care providers, if you have questions about patients or the procedure, I am always open to discussion. You can send me a message through Haiku or contact the office and my office will put us in touch. I do want to thank the Prostate company. They provided a lot of these slides for me to be able to give you this presentation. I thank you for your attention, and let's move on to some questions. So we have a patient who's asking, I have a Muskegon-based urologist. Their office does not perform aquablation. Are you seeing new patients? So absolutely we are. I do have some patients who are coming from out of town to actually come in for their aquablation therapy. First step would be talk to your primary care provider, and they can usually put the referral into the system, and they would just need to fax over the order or send it electronically, and our office can contact you to schedule an appointment, and we can get you checked out. Next question, does insurance or Medicare cover this procedure? So that's a very good question. Vast majority of insurance companies now cover this procedure. The Medicares and the federal insurances definitely cover. There's a small handful of private insurance providers that are not yet on par with the procedure, but we're working on getting those to provide coverage. Prior to the procedure, we always check a prior authorization. We make sure that the insurance would cover it before we perform the procedure. So the next question, where is the instrument inserted into the body? Good question. So I had mentioned that we insert two instruments. One is the camera. That camera is actually inserted through the urethra, through the penis, and into the bladder. The ultrasound is inserted into the rectum underneath the prostate. How long before outpatient is a possibility? So I believe what you're asking is how long before we are actually discharging patients on the same day. I've offered a couple of my patients, or a few of my patients, the opportunity to go home in the afternoon. Actually, to my surprise, most of them actually wanted to stay overnight just to be monitored. We're starting for maybe some smaller prostates to, especially if it's done very early in the morning, to offer, potentially a discharge in the afternoon. We usually will place them kind of in an observation status so that we can monitor them throughout the day, take off the traction, stop the CBI. I am actively kind of pursuing for smaller prostates, doing this as an outpatient procedure. So hopefully soon. And if that's always a worry for you, you can always talk to me about that, and we can plan accordingly, potentially get you on it first of the day and potentially get you out before the end of the day. Sorry, I'm just reading some of the questions. I'm getting some comments as well. So if I just started taking doxazocin due to lower stream of urine only at night, when is it time to come see you for an evaluation? I don't want to wait too long. So typically what we recommend is we start the medication therapy first, and we'll usually keep you on that medication therapy for about 3 to 4 weeks. It will probably take a little while for you to get into the office, whether it's our office or another office. So if you're not having relief, doxazocin and doxazocin is type of alpha blocker. Alpha blockers generally tend to work relatively rapidly. So if you don't have changes to your symptoms within a week, generally that it's not going to get too much better from there. So if you're not really having relief with that doxazocin, I would say talk to your primary care provider, send a referral over, and we can see you in the office. Next question. I have a nodule that is on top of the prostate. I was ultrasounded via my anus a few years ago. Will this matter? So that's a very good question. I guess it depends on if you have prostate cancer. Patients can have nodules that are benign on their prostate. We see quite a few patients that get referred, they have an abnormal rectal exam. We have to kind of work them up, rule out cancer. So if that nodule is present, but it is benign, it will not change our management at all. we can still do the procedure without any issues. If we have a nodule and your PSA is elevated and you have not had the previous workup for prostate cancer, I will usually do that workup for the prostate cancer to make sure that we don't have an underlying prostate cancer before we talk about doing aquablation therapy. Now, the next question that somebody may ask is, if I have prostate cancer, can I get this procedure? If you have a diagnosis of prostate cancer and you're undergoing what's called active surveillance, where you're watching your prostate cancer, oftentimes we can still do the treatment for the enlarged portion of the prostate. I mentioned in first couple slides that an enlarged prostate does not increase your risk of prostate cancer. They're two mutually exclusive, two separate disease processes. So if you have prostate cancer, we can still treat the enlarged portion as long as it's not a high-grade prostate cancer. If you have a high-grade prostate cancer, typically I'll recommend we are more aggressive to treat the prostate cancer, usually by removing the entire prostate gland. I hope that answers your question. So I'm already a patient of your practice. Do I still need a referral to be evaluated by your aquablation? This is anonymous, so I don't know what your name is, but absolutely not. If you're already in our practice, if you're already established, you just need to talk to whoever you see in our practice and tell them, hey, I'm interested in the aquablation, and we can get that started for you. Does Blue Cross of Michigan cover? For the most part, yes. Blue Cross was one of the ones that was a little delayed in covering, but as of April of this past year, Blue Cross Blue Shield does cover this procedure. Now, with most of the insurance companies, we do have certain criteria that we have to meet, and we do usually do the workup to make sure that we meet those criteria prior to performing the surgery so that they will cover that procedure. Again, if you come in, if there's a concern about, having the procedure covered, we can always send a prior authorization or kind of go through the process to find out if the insurance would cover. My PCP is with Trinity. Will he be aware that I participated in this webinar? I'm not sure he would be actually notified that you were in the webinar, but if you are interested in potentially undergoing aquablation or going through the BPH workup, you can definitely talk to him or her and have them send a referral over. And again, we'd be happy to see you, or one of the other urologists would be happy to see you. So can this be performed without general anesthetic? At this point in time, not yet. I had mentioned in the first few slides that a few of our procedures, mostly the non-resective procedures, can be performed in the office or the surgery center setting under local anesthesia. Urolifts especially, often I'll do them right in the office. You're awake for the procedure. We may give you a little bit of Versed just to kind of calm your nerves. And mostly it's under a local anesthetic. So we use lidocaine to numb things up. Unfortunately, aquablation has to be performed under general anesthetic. It is a little more invasive than you would want to be awake for. Can I have an aquablation if I've had a different procedure in the past? So this is a good question. Absolutely. So we have a lot of patients who come in, they've had a TURP in the past, they've had a laser vaporization in the past, they may have a Urolift in the past, and they have that regrowth of tissue. Prostate, any of these procedures, whether you do the Urolift, the non-resective, TURP, simple prostatectomy, you are leaving part of the prostate behind. We're not removing the entire prostate. So that remaining tissue does continue to grow. And in general, prostate grows at a rate of 10% per year. So, we have patients who come in all the time. 20 years ago, they had a TURP, did great. But now in the last few years, they're starting to have symptoms again. We can evaluate, we can do the ultrasound, we can take a look inside. And if you do indeed have regrowth of that prostate, oftentimes it can even look like you've never had any surgery. We can absolutely do that aquablation again. Is it okay to get mapped out before you need to do the procedure, before the aquablation? So a few years down the road, you're already working out with a good map. So that's a good question. So generally, we perform the workup. So we do a cystoscopy, the camera in the bladder, camera in the prostate. We perform an ultrasound to get a volume of the prostate beforehand. This is more for to determine what is the optimal therapy for you. Are you an adequate candidate for the aquablation therapy? Some patients come in, they have, maybe a cystoscopy or a camera in the bladder that was performed by their urologist, as an outpatient. They may have had a transrectal ultrasound performed for, let's say, a biopsy, or even workup for treatment of their enlarged prostate. Generally, I do repeat those because, my cystoscopy might be a little different than the guy down the street. I don't necessarily, I'm sure urologists have a general sense of how to do good cystoscopy, but I like to see with my own eyes what's going on with the prostate before I actually operate on the prostate. And I think it's good for you, it's good for me to do that. Now, that mapping that we do is in real time. So we don't necessarily create that map with the borders and the treatment zone until we get into the procedure. And the procedure itself is done with the ultrasound and camera in place. So no matter what, we will have to put the camera and the ultrasound in during the surgery itself. I believe that answered your question. I hope it did. Do you need to have antibiotics before and after the operation? So in general, we do a dose of antibiotics at the time of surgery, and for generally the 24 hours you're admitted into the hospital. That's pretty standard for any invasive urologic surgery. So if you're having, prostate surgery, if you have kidney stones, if you're having another procedure on your ureter, everybody gets a preoperative antibiotic. And generally, if you're admitted, antibiotics for about 24 hours. Now, prior to the surgery, I do perform a urine culture about 1 to 2 weeks before. If it's negative, then we do the standard preoperative antibiotic like we discussed or what I just mentioned. But if it does come back positive, then generally I like to have you on antibiotics for 3 to 5 days before the surgery. And I tend to keep you on for a few days after, just to make sure we're not going to have any lingering infections. Just a comment from one of my patients. I'm a patient. I had the procedure. It worked great on me. I recommend it. Good job, doc. I appreciate it. I'm not going to name any names, but I appreciate it. What hospital do you perform the procedures at? So as of right now, we perform it at St. Mary's Hospital, Trinity Health Grand Rapids in downtown Grand Rapids. What makes you decide how long the catheter stays in place? Good question. Everyone's a little different. Generally, at the time of surgery, I can usually predict how much bleeding is going to occur after the procedure. Smaller prostates, we may keep them in a little for a shorter duration, 2 to 3 days on average. For very large prostates, I may keep them in a little longer, 3 to 5 days. A lot of our patients come in, they have very large prostates and they're in urinary retention. So the bladders cannot empty and they have catheters before they go in for the surgery. For those patients, I do tend to keep them in for at least a week prior to removing them. That's just to allow the prostate to heal, give us the best chance at being able to, for your bladder to be able to kind of empty out the urine. So I think that's all the questions. If anybody else has any questions, feel free to post in the Q&A. Otherwise, Megan, I believe we're done.
Yes, thank you very much. We will wrap up a little early and give everyone the gift of time. Thank you once again to Dr. Mander for a wonderful presentation and Q&A session. Our next Wednesday wellness topic will be on Valentine's Day, which falls on Wednesday, February 14th, and will be at 12 p.m. The topic will be discussing women's heart health, and we will also be hosting a second webinar on February 21st at 7 p.m. that will be discussing the topic of understanding your vein and artery wellness. A link to register will be included in our follow-up email that will be sent out early next week. Thank you for joining us, and we hope you have a wonderful rest of your evening.
Thank you very much for having me.